So this is about inflammatory bowel disease. Questions still frequently come up about inflammatory bowel disease. It's not sort of cognitively and conceptually a terribly exciting subject, but because it still frequently comes up, that's why we're going to cover it in the course. Now, these lists of things that distinguish ulcerative colitis from Crohn's disease, this list here, I'm not going to dwell much on this because you've been going through this whilst you've been in medical school and you've been going through it every year, and you've probably been wondering why is it that they keep on asking me the same question again and again and again. And the reason being is some unfortunate people are going to end up as gastroenterologists, good private money, unfortunate for you. And if you end up as a gastroenterologist, most of your bread and butter work is going to be deciding whether somebody has got Crohn's disease or ulcerative colitis. And it's not as easy as it sounds. You may end up relying on observational findings that you see to end up making the diagnosis rather than you just take a biopsy, you send it to some clever lad in pathology, and he makes it for you. In fact, the diagnosis for ulcerative colitis is a clinical diagnosis. It's where is the disease, what does it look like, rather than I take a sample of it and somebody else is going to tell me what it is. Crohn's disease, yeah, you might take a little biopsy, they send it off, you see non-caseating granuloma. Based upon that, you're fairly persuaded that this is going to be Crohn's disease. So the diagnosis with Crohn's disease is a pathological diagnosis, whereas one for ulcerative colitis is a clinical diagnosis. Nobody's going to tell you. You've got to work it out for yourself. Things to help, though, are in an exam, if there are fancy X-ray findings, so they're talking about stuff on X-ray that looks fancy, then the diagnosis is probably Crohn's disease, just to help you remember if you haven't learnt the list by now. The fancy things, cobblestone, that sounds a bit fancy, rose thorn ulcers, string of Cantor, whereas everything on the ulcerative colitis, featureless polyps and thumbprinting I've got up there, but you can get thumbprinting with anyone, so I think I've removed it from your book now. It's no longer there. You don't really see much on ulcerative colitis, but you get some fancy stuff with Crohn's disease. The question that's likely to come up in your exam are those things that often run alongside the diseases. What complications you get? Are they found more commonly in ulcerative colitis, or are they found more commonly in Crohn's disease? And the pattern, that if you start picking it apart and looking at it, if it happens in the liver and the biliary tree, or in the bowel itself, anywhere along this pathway, that happens much more commonly in ulcerative colitis than in Crohn's. So, autoimmune hepatitis happens much more commonly in ulcerative colitis. Primary biliary cirrhosis, primary sclerosing cholangitis, toxic megacolon, bowel cancer, all of those things are found much more commonly in ulcerative colitis. If it doesn't fall along that pathway between the liver and the bowel, it doesn't fall, then it's found more commonly in Crohn's disease. So if I said episcleritis, what's that found more commonly in? Crohn's disease. Thromboembolism, what's it found more commonly in? Ankylosing spondylitis, which is it found more commonly in? Autoimmune hepatitis, we've already said ulcerative colitis. So actually it gets really easy when you're given that list to pick out which ones. Renal stones, it's going to be Crohn's disease. And the list goes on. Skin manifestations, erythema nodosum, pyoderma gangrenosum, what are they found more commonly in? Crohn's disease. So suddenly the question when you've asked which of these, where are they found more commonly in, becomes a very easy question to remember. If you remember anatomically, from the liver down the biliary tree into the bowel, those complications are found much more commonly. Now, ulcerative colitis, you've been taught that the distribution is from the most distally and then it works its way proximally. So it's found in the lower part of the bowel. And if you were in somebody with really severe ulcerative colitis, to put a colonoscope into their bowel, which is quite thick and less flexible than you think. You could easily perforate it. So in somebody with severe ulcerative colitis, the investigation that you'd like to do is a flexible sigmoidoscopy, not a colonoscopy. So, you know, somebody comes in and they've got bleeding, rectal bleeding, lower GI blood loss, they've got bloody stool. What investigation do you ask for? You ask for flexible sigmoidoscopy. Firstly, that's most likely where the pathology is going to be found. Secondly, you don't want to end up perforating their bowel. If on flexible sigmoidoscopy everything looks okay, then yeah, you're going to pop a colonoscope in and have a look a little bit further. But first line of investigation is flexible sigmoidoscopy. If I came in to your A&E with my initial presentation of Crohn's disease, the likelihood is I'm not going to come in with rectal bleeding. I'm going to come in with abdominal pain. If I presented to your emergency room with ulcerative colitis, it's probably going to be with large amounts of blood and frequent stool. So actually, when somebody's presented and they've got abdominal pain and you're thinking inflammatory bowel disease, and they're not having large amounts of blood and stool, then you can probably go straight for a colonoscopy. But if you think it's severe ulcerative colitis or they're just losing blood, the first investigation is flexible sigmoidoscopy. So, now we've identified that fancy X-ray findings are more commonly found in Crohn's disease, that anything along the pathway from the liver to the bowel more commonly occurs in ulcerative colitis. How do we treat these? We start off by giving them steroids. I'll just call it usually prednisolone. You might have seen they've come in and you've ended up giving them hydrocortisone when they come in. Doesn't really make any difference. Hydrocortisone, prednisolone, dexamethasone, they all do exactly the same thing. There's just varying potencies associated with them. So the number associated with the dose is smaller, and that sometimes you feel better. I feel more comfortable giving somebody 16 milligrams rather than 128 milligrams of prednisolone. In my head, that's just a little bit more comfortable. 8 times as strong dexamethasone to prednisolone. So steroids. Steroids you should only use to induce a remission. Induce. Then you want to maintain your remission. Thankfully, the treatment ladder for ulcerative colitis is exactly the same as the treatment ladder for Crohn's disease. Even though some of the drugs don't work in one condition than they do in the other, it lengthens out your outpatient appointments, and hopefully their bowel disease will get better on its own and by that time. So you maintain a remission. These are the 5 ASAs. So somebody comes in, they have bloody diarrhea, you order a flexible sigmoidoscopy, you start them on steroids, you bring them back into your clinic, if you're a gastroenterologist, in 2 or 3 weeks' time. You start bringing back them on the steroids and you start them on a 5-ASA. And hopefully you'll get rid of their steroids entirely, and their 5-ASA on its own will maintain this remission. Then, a month later, the person ends up in the hospital again. They're back, oh, I've got another flare of this. You need to induce a remission again. And you'll induce that remission with steroids. You give the person hydrocortisone and then discharge them with prednisolone. They come back into clinic and you try and get rid of their prednisolone and maintain them with remission. Maintain them in remission with 5-ASAs. After a while, it will become clear that 5-ASAs aren't doing their job on its own. So then you move on to azathioprine. But both of these are about maintaining remission. Now, you may end up on azathioprine and you still keep on going around this loop. You're on azathioprine, you've been started on the medication, and you're still coming in every 6 weeks requiring more steroids to get your disease under remission. And that's called treatment failure. And if somebody fails treatment, then you chop that section of bowel out. In ulcerative colitis, that could be curative. In Crohn's disease, you're taking out the offended segment, and then you wait for a period of time until they get another offending segment. And then throughout their period of life, you start removing more and more sections of their bowel, and it's unpleasant. 80% of the people with Crohn's disease end up having surgery at some point. Only about 15% of people with ulcerative colitis do. So surgery is much more common in Crohn's disease than it is in ulcerative colitis. Now, there maybe some of you have done gastroenterology before, and you say, what about this infliximab? I remember I've seen people being started on infliximab without having surgery. Nice guidelines would say, in Crohn's disease, if you're not suitable for surgery, and you failed everything else, then you can try infliximab. Now this stuff is really good stuff. I mean, it works extremely well in both controlling symptoms and disease process in Crohn's disease and ulcerative colitis. They haven't entirely finished the trial process for infliximab in ulcerative colitis. So that's the reason why that NICE says only in Crohn's disease. But it works very well. So that's why in clinical practice, sometimes when you've had a lot of clinical experience, in the exam, you can end up being stuffed up by your clinical experience, because you will find gastroenterologists that say, they failed this treatment. I can't send somebody to go and have a section of their bowel chopped out, suffer on the hands of a surgeon. When I know that there's another drug that I can try that is extremely good at controlling the disease process. In good conscience, I can't do that, even though that's what the NICE guidelines are, which is what you will be examined on, the NICE guidelines, that in clinical practice, people end up being put on infliximab before they get sent for surgery. And that's, you know, if it was me, I would want a trial of the infliximab before I let some bloodthirsty idiot cut me with a knife. I might survive the operation, but the fluid balance of the hospital-acquired pneumonia and the pulmonary embolism later, no. I'm going to go straight and answer the question now. A young man of short stature presents with a 3-month history of abnormal bowel habit. Now, as soon as they bring in short stature, you're thinking about chronic long-term inflammatory diseases. That's what you're thinking, or chronic renal impairment, or chronic, those are usually the types of things, but very non-specific. He's been passing bloody stool many times per day. You suspect he has inflammatory bowel disease. Signs of a genius. Concerning the diagnosis and treatment of inflammatory bowel disease, which of the following is true? Visualization of the bowel in severe ulcerative colitis should be obtained with colonoscopy. No, we want to do flexible sigmoidoscopy because we don't want to perforate that very friable part of end bowel. Azathioprine and methotrexate should still be used before infliximab to treat Crohn's disease. So that answer is true. You can't treat somebody with infliximab before you've tried them on azathioprine. And if you flip onto this back page, there's the treatment of inflammatory bowel disease, which is exactly what it is that I've written up on the board, bar for the fact that it's no surprise that gastroenterologists are saying, okay, well, I might not be able to get my hand on infliximab because my trust is cutting back and we've got no money left in the coffers. I don't want to send them for surgery, but actually I remember that azathioprine worked in a very similar way than methotrexate and cyclosporin and cyclophosphamide. So gastroenterologists will try these other things as well now. What we know is 5-ASAs don't really work in Crohn's disease. We will still start everybody with Crohn's disease on 5-ASAs, even though there is no evidence base behind it. Because if we give it to them, then the patient might go home and their Crohn's disease might get better on its own. Yeah, give it. Yeah, they're very, very, very cheap to give. So yeah, give them. And what you can do is when the patient comes back to clinic and saying my 5-ASAs don't work, then you can fiddle with the dosage and you can fiddle with the make and send them away again. And eventually, after trying them on a variety of 5-ASAs, their Crohn's disease may subside and go into remission on its own. If not, you're going to go up to... The question is a right answer that you start the person with Crohn's disease on 5-ASAs. If the question is, does it work? The answer is no, it doesn't work. But it gets them out of your clinic room. So yes, that's the correct answer. 5-ASA medications are more effective in the treatment of Crohn's disease than ulcerative colitis. Well, no, we've just been talking about that. That's not true. More patients with ulcerative colitis end up requiring surgery compared to those with Crohn's disease. No. 80% of people with Crohn's end up with surgery. 10 to 15, 20% maybe at maximum with ulcerative colitis. Rose thorn ulcers are associated with ulcerative colitis. That's a fancy X-ray finding. That's got to go in the Crohn's bracket. Now, we were talking a minute ago about that livery process, autoimmune hepatitis, primary biliary cirrhosis, primary sclerosing cholangitis, toxic megacolon, and bowel cancer. Those are all things that are associated with ulcerative colitis. The bit that I want to focus on just for 6 minutes, I think we've got left, is the cancer part. You are more likely to get cancer and ulcerative colitis if you've had really severe colitis that's been affecting large amounts of the bowel for a very long time, and especially early on in your life. So if you're young with pancolitis for greater than 10-year period, then they usually monitor people every few years with colonoscopy to see whether they're developing bowel cancer. So this is pancolitis of early onset, greater than 10 years. That's on somebody with a UC. Now, although ulcerative colitis is a risk factor for bowel cancer, most people who get bowel cancer, it's sporadic. So about 75, 80% of people, we don't know what happens, they just get bowel cancer. It's either to do with they've got a love of burger or red meat. Whatever the reasons are, these are sporadic. There's also a small number of people who seem to have inherited cancer syndromes that predispose them to getting bowel cancer more than their next door neighbour. And the most common hereditary cancer syndrome that causes bowel cancer is hereditary non-polyposis colorectal cancer. There have been a variety of different countries that want this name changed from hereditary non-polyposis colorectal cancer. This is a hereditary cancer syndrome where you are at much higher risk of, for want of a better word, womanly cancers. And womanly cancers are put in the category of breast, of ovarian, of uterine. You're also at higher risks of stomach, gastric, and bowel. So it's a little bit unfair to term this hereditary non-polyposis colorectal cancer, because although you are at higher risk of bowel cancer, you're also at higher risk of breast, ovarian, and uterine cancer. So they have been trying to, for a period of time, change this to hereditary cancer syndrome, but they haven't at the moment. When you look in these people's bowels, they look normal, because there aren't loads of those little polyps like there are in familial adenomatous polyposis coli, FAP. How do you then decide that somebody fits into this? And there is a mechanism using the Amsterdam criteria. And you're probably too old to remember 3, 2, 1 and the little dustbin thing around. No. Okay. 3, 2, 1. You need 3 relatives. Do you remember? No? It's a sad thing as you see your age marching on, because some of the things that you use to help teach become less and less relevant as time goes on. But 3 relatives with cancer, spanning 2 generations, and 1 person who has had that cancer is aged less than 50. That's the Amsterdam criteria. Not to be mixed up with the Rome criteria. These are people who come into clinic and they think that they've got something wrong with their bowel, but actually they've got irritable bowel syndrome. Now, it's often easy to put these people into the category of being mad, but they're not mad, probably not mad. They've done investigations of people with irritable bowel syndrome and fibromyalgia, and that's the rectal balloon test. And they got a section of normal volunteers and people with irritable bowel syndrome, and they put a balloon into the rectum of both the volunteers. Why you would volunteer, I don't know. Self-selecting group almost. And then you have your people with IBS, also balloons, and then they pumped up balloons and measured the volume of the balloon before the person said that I now have pain and can you stop? And the people with irritable bowel syndrome had much lower balloon volumes before it induced pain. So then you thought, well, maybe they're just whining a little bit more than some of the volunteers. So they then put them through a PET scan, functional MRI as well, to look for areas of thalamic activity, to see whether the thalamus started glowing to say that they were actually feeling pain. And indeed, those people with irritable bowel syndrome and fibromyalgia had thalamic activity at much lower rectal balloon volumes than normal volunteers. So it's easy to think these people come in complaining of pain. Although people who you hypnotize, you can get to feel pain and have thalamic activity at fairly minor amounts of stimulation, so that maybe this is learnt and it's a behavioural thing anyway, but you can decide for yourself. The Rome criteria. I think of this as you have frequent pain and mucus. That's frequent. So the frequency, their bowel frequency, is either less than 3 times a week or more than 3 times a day. These people who have pain, which is worse on eating and relieved defecating. And mucus is also found. So The fact that you find mucus in stool doesn't necessarily mean that you've got an organic pathology going on. You may be mad. Sorry, you may have IBS. Frequent pain and mucus. So Amsterdam criteria, familial adenomatous polyposis coli. Just the last part before we stopped, we've got a tea break going on, this is APC, the APC on chromosome 5, and HMPCC, HMLH1, and HMSH2. Those are the genes that are associated with it, and I won't prolong randomly associated facts too much, but people who get sporadic cancers also seem to have the same, when you look at the cancer itself, they seem to have the same genetic abnormality in the cancer, a defect on APC chromosome 5. Now, what do you do with these people? People with familial adenomatous polyposis coli, you look into their bowel, and even when they haven't got bowel cancer, you've got thousands and thousands of polyps within their bowel. These people will eventually get a cancer in one of those polyps, and you won't be able to find it because you don't know which polyp the cancer is going to be in. So these end up having a colectomy. You do a prophylactic colectomy in the patient's 20s, and they just take out the colon. These people, if they come in and they say, I've got a family, 3 relatives with bowel cancer, covering 2 generations and 1 age less than 50, you monitor these people and you do colonoscopies every 4 or 5 years. So these people are monitored with colonoscopy. And then when you see something appearing from the side wall, you biopsy it. If it looks cancerous, then you remove it, or you have to remove that section of bowel, so you monitor. At the moment, because our country is still treating it as hereditary non-polyposis colorectal cancer, it's bowel cancer, yes. But actually, in time to come, by the time you're registrars and consultants, you will be probably looking for any one of these types of cancers and doing a slightly different pattern. But for the moment, it's bowel cancer that we do it. Have I covered everything? Yes. Any questions? Okay, we're going to stop for tea break. It's